Nothing on the Bonnell Foundation's Living with Cystic Fibrosis podcast should be considered medical advice. Medical advice can only come from your CF physician. Cystic fibrosis can be a devastating diagnosis, but living with the disease can bring positivity and a new appreciation for each day. From the Bonnell Foundation in Detroit, Michigan, it's the Living with Cystic Fibrosis podcast, sponsored by Viatris and Genentech. Here's your host, Laura Bonnell.
I feel like Bob is everywhere and supportive of everyone. Without a DNA connection to cystic fibrosis, Bob Emmelkamp became a lifelong CF fundraising volunteer in 1976 when he helped put on a high school dance marathon where proceeds benefited the Cystic Fibrosis Foundation. And since then, he has raised hundreds of thousands of dollars to advance research for a cure for CF, spreading the word and explaining the latest CF research news, and personally funds grants to the labs of some of the top CF scientists. For the past 20 years, Bob has attended the annual North American Cystic Fibrosis Science Conference. In 2017, he received a special invitation to attend the European Cystic Fibrosis Society's exclusive CF Basic Science Conference in Portugal and was asked to create and present a poster on the changing nature of interactions between research scientists and patients. And after this podcast, if you didn't know who Bob was, you're going to be addicted to his science talk, just like I am. He is so great and explains everything so well in this podcast. We really had a lot of fun doing this, and I can't wait until we do the next podcast together because he has such insight and such knowledge, and I really appreciated it and can't wait to talk to him again. So, Bob, it's great to talk to you. We're sort of face-to-face, but at least we're on the same platform. And I love the fact that you are the spreader of CF news and information. And I also know that you have a fun fact to tell us about your Michigan connection.
I do. I was born at Henry Ford Hospital, and our childhood home was not very far from Rouge Park. So I went ice skating on Rouge Park when I was a kid.
And I don't know how people might not know, but Henry Ford, Ford Motor Company and all of that. So the hospital is in his name, of course, and different, but that is really a cool connection.
It is.
We have been friends on social media and we support each other and we're in the same atmosphere of this beautiful CF community. But tell us how you came about and started on your CF journey.
That's actually pretty simple and easy. In my high school National Honor Society, we chose cystic fibrosis for our charity project. But I think the real question is, why have I stayed involved for 47 years? And the answer to that is I fell in love with the science and with the amazing CF community that you just mentioned.
And the science, I'm not smart enough. If I had the brains, I would have been a scientist, but it's way above my smart capability. But I have so much respect for you and others who just get it and live it. And I love when it's explained to me and when I understand. And I just think it's incredible all that scientists are doing. And I want you to tell the story that you just told me when I was at the CF conference in Nashville, because then I was interviewing Dr. Francis Collins and we were doing a podcast. And I didn't realize we were both there in the same spot.
We were. So you were actually, it was like a hallway in the conference center, and you were on a little bench with Dr. Collins. And I realized you were doing your podcast, so I didn't interrupt you, even though I was tempted to, just because two of the most important, you and as well as Dr. Collins are heroes. But it was just amazing to me that we've had someone like Dr. Collins involved. And I also happen to be good friends with Dr. Reardon, who's one of the other co-discoverers of the CF gene. So it's been an amazing privilege to have been involved with this for so long and to meet some of the amazing people that have made it possible.
Right? Isn't it just legends that we have been living amongst and have gotten to know, and that are so down to earth and so kind and giving of their time and all that they know. Not to veer completely off the rails, but I know you can relate, because when COVID started and there was our hero, Dr. Francis Collins, and people were disrespecting him and saying things because they didn't know any better, which isn't an excuse for them, and we know who he is, and what an honest and giving scientist he is. That was so disturbing to see all that flying around about him and Dr. Fauci when we know who these people are.
Yeah, I think it definitely had an emotional connection for me, having lived my whole life, if you will, connected to science, and knowing that science is the only thing that's allowed us to increase the lifespan of CF patients, as well as so many other diseases. I grew up, got a polio vaccination, measles vaccination. So it just was very difficult to hear people that, unfortunately, from a place of ignorance, not understanding not only, like you said, the amazing science that was being put forth to deal with COVID, but also the true heart of the people involved, people that have given their whole lives and their whole heart to making a difference in the lives of those that have healthcare challenges.
Right? And not a mean or vindictive bone in their body. Like, it's against their whole nature. They couldn't if they tried.
No, exactly right.
I mean, yeah, it was very disturbing, and really wanted a platform that was bigger than everything else to say, hey, wait a minute. Do you know who you're talking about? You don't know who you're talking about. Greatest man alive, honestly. I mean, amongst them, he's done so much for the world.
Yep.
But back to you, another great. I am really excited to talk to you because you're everywhere and you're so supportive of all of us in the CF community. I just want to know, what does that mean to you to be so connected and to see all the nonprofits and all of us in the CF community, what everybody's doing? I mean, we're a tight-knit community, and then we go in different directions and help differently throughout the United States. But what does it mean to you to see all of this energy?
It's really been an amazing journey. Again, looking back, almost it'll be in a few years, 50 years of involvement. But that I've been able to see all the different ways people try to help, whether it be different fundraisers or different activities, different books that have come out. It's been something that has inspired me. And also, you've got to realize, back when I started, children didn't make it much past elementary school. And to now have lifespans that could be 50, 60 years and beyond is totally amazing. But it also truly has sped up in the last, let's say, 5 to 10 years, definitely the last few years. Research, we've been really good at attracting some amazing research from all different fields. And we're going to have to keep doing that to make sure that we cure cystic fibrosis.
Absolutely. And now to get back to your love, science, what is the latest research and treatments for CF that you are most excited about?
Well, I get excited about lots of research, but there's 2 companies right now that are testing inhaled gene therapies. One of them is called 4-DMT. They have a compound called 4D-710 that they just published some data on with some CF patients and how they did. The other company is Crystal Biotech. That's Crystal with a K. And again, these are lung therapies, so they potentially have the most effect on the organ that's most affected by cystic fibrosis. But at the moment, these would be treatments to help with that. But to see an actual gene therapy that was effective is very exciting to think about. I was there in 1989 at the time that the gene was discovered and announced. We thought we were done then, which was a bit premature. But to see it actually come to fruition now is an amazing time.
Gosh, we've been together forever and we just didn't know it.
Yeah.
I was there for the news conference and everything, which I've talked to Dr. Collins about. It's the same thing that Dr. Collins said. We thought we had it. And then we realized, wow, it's just the beginning. Like things didn't go speedy fast back then. It took a long time.
It did.
Why don't you explain? Not everybody knows what gene therapy is. Talk about what gene therapy is and what this inhaled compound, how it would work.
So basically, the idea is you can take either a slightly shortened version of the CF gene or a full length of the CF gene, and you can get that into cells. And what that means is that the cells would then start producing that gene, producing a proper protein, if you will, whereas anyone who has CF, their protein is defective in some manner. And so this would put, in essence, the correct instructions into the cells. If you're able to target the right lung cells, you actually could have a very long-lasting, if not somewhat permanent effect on those cells so that they would actually work and produce the proper protein. And for both of the therapies I talked about, they would work for people that are in that 10%. So it doesn't matter whether you have the most common mutation or a rare mutation. These would be therapies that would be effective, potentially effective for any of those patients.
And I have so many questions off of this, but would this be something you consider is a cure, or is this still something that's correcting the underlying condition of the disease?
I think we're just short of a cure for these, and we'll talk about it a little more, I think, later in some of your questions that you might have, but this is not going to, at least so far, been proven that would go beyond the lung. And as most people with cystic fibrosis know, there are problems in the digestive system. There are problems all throughout your body. So these particular therapies are not what I would put in the class of a cure, but they're definitely getting us very close to that.
When I was talking with the scientists at Translate Bio, which has since been bought by Sanofi, they had an mRNA inhaled, I don't know what it would be called exactly, but that has now, as far as I know, is that still going on? Was it picked up by someone else, proteostasis or anybody else?
I believe it is still being looked at. I don't remember for that particular one whether they saw, at least when they were doing their initial testing, enough efficacy to continue. It can be very hard because anytime you're trialing a new treatment, you really are looking for indicators that you're having a positive effect. And there are just times, there can be different circumstances or different formulations that may affect whether you're actually getting that or not. Again, it's the same idea, whether you're talking about a gene therapy or an mRNA therapy, that you're trying to create a correct protein. The only big difference is that an mRNA, which we should all be familiar with, hopefully from COVID, because most of the vaccinations are made of that, is that it is somewhat short-lived. There could be an exception, but you would expect you would have to give an mRNA therapy repeatedly. Now, that might mean repeatedly 4 times a year or something like that, as opposed to a gene therapy that might be a much, much longer effect.
And that is a great way to explain it. I'm sure that helps people understand. I mean, I think science is so interesting. And then when someone like you, Bob, when you are explaining it in a way that everybody can understand, that, I mean, it's very helpful. Then people are like, oh, okay, I get that. That makes sense. And I think the interest grows from people. It's a problem if you don't understand something and you just think it's way above your ability to learn it, right?
What's interesting is my time hanging out with scientists, which I'm really blessed to be able to do, some of the smartest people in the world, is that they've told me that if anybody themselves, or if you can't explain something so that the average person understands it, then you're not doing your job right. And so I definitely take pride in that I'm able to translate the science for people, but it's also because a lot of those scientists, as you said, with their big hearts, have been willing to sit with me and translate it to me so that I can then translate it to other people.
And that is a beautiful thing that you're able to do. and tell us all the places that you're explaining what science is and what it can do.
I have some different things. I attend the NACSC, the North American Cystic Fibrosis Conference. When we have our donor meetings, if you will, in Phoenix, I just gave a talk on the way to science to any of our donors. And again, doing my best to explain it so that they understand not only that their money that they're raising is making a difference, but they actually understand what it means for their children or their young adult children, or that they know that some of these treatments as well have potential benefits to other diseases. And I think that's always inspiring to donors to do that and make a difference.
I agree. I think it is as well. Now we're going to kind of skip over to phage therapy. I mean, it's been around longer than most of us know, but it's really become popular to talk about now and being addressed in more than just cystic fibrosis, but in the rare disease community as well. But there do seem that there are things that are stopping it from getting where it needs to be. In speaking with Diane Shader-Smith, who recently came in for our education day and talked to all of my parents, she even talks about just getting the basic name so that everybody knows what we're talking about. Like some people call it a superbug. Some people call it
Bale,
microbale in another study, etc. If you can explain what phage therapy is, and this is something people not just with CF are going to need. I think Madonna probably after her infection and so many others.
It really is. I like to call them bacteriophages.
Okay.
Like you said, there are definitely multiple names. Part of that is we are talking something that's been around. Actually, I think the Russians discovered this maybe back in 1800s even. But
wow.
These are basically naturally occurring viruses, and they could be anywhere. They can be in pond water. They can be in soil. They can be really anywhere on the earth. These viruses can occur. And these viruses have the ability to kill bacteria. And when you imagine things like bacterial resistance and antibiotic resistance that we're all kind of dealing with now, to have a new way to kill bacteria that doesn't promote resistance being built up, mutational resistance, is really promising. The trick to these, and the reason that you're seeing so much of a drawbacks or roadblocks, is that to produce these viruses in a quantity and a purification is a very delicate process. There's a lot involved to make that happen. And perhaps the biggest roadblock may be, we don't know this yet, but you might have to have a one-to-one match between the selected bacteriophage and the specific bacteria of that patient, not just the type of bacteria, but the actual, that patient's bacteria, which if that was true, we don't know that yet. We're still trying to figure that out. Mm-hmm. But if that were true, that would mean these treatments would be all one-offs, which makes them potentially time-consuming and expensive. And unless you're Madonna that can afford it, it might not make sense. Now, what we're hoping is that the scientists can figure out a way to have more of a, if you will, an off-the-shelf type of thing that would be, so a bacteriophage that would be effective against Pseudomonas no matter what patient it's given to. And actually, they're trying some things, a cocktail of bacteriophages, which seems to actually be showing some potential. So it is a really interesting thing. There is definitely a lot more work to do, but it's definitely been something that's moved forward, I would say been pushed forward because of different people like Mallory Smith's condition and that Diane spoke to and things like that, that say, hey, we need to solve this. And that's something that needs to happen.
And it's something that everybody should be concerned about because there are so many different bugs that I guess that we would call it that all of us can get. And Diane, really believes, and I think the evidence showed that this could have saved her daughter, Mallory, if they had started sooner. I'm not sure. But yes, all the bacteria that's in our kids' lungs, like the microobsessive bacterium and Pseudomonas and B. cepacia and all of this are deadly to our kids if we can't figure out a way to fight it, correct?
Correct.
Do you think we're going in the right direction? Do you think that people are listening and we're kind of focusing better in this regard?
I think it is. Again, we just saw some congressional hearings on the antibiotic resistance. So I think bacteriophages are one of many tools in the toolbox, if you will. It does need to be refined. It does need to be found a way to be in a production process that makes sense and a off the shelf, if possible, rather than being tailored for each one. Although, again, we have seen with the Vertex modulators and things, the fact that you're genetic specific, it wouldn't be out of the realm to say that your Pseudomonas would have to match a certain gene profile, and then you could use XYZ bacteriophage. But I think we are progressing down the road the right way on it.
And you were referring to the Pasteur Act. Is that what you were
Yes.
talking about? Okay. Yeah, there's been a huge effort by all of us, right?
Yep.
To make that happen. I mean, so many people are doing so much to get that going, and it would benefit everyone. And so now we're kind of still talking about Pseudomonas. There might be an immunization that might be able to protect patients from Pseudomonas.
Yeah. So the interesting thing is there was just a Science article published earlier this month where they tested in an animal model that was able to immunize against pneumonia caused by Pseudomonas. That is interesting, and it looks like that after a lot of testing, kind of a long ways off, we might have something that would look like a vaccine against Pseudomonas. But I think more interesting, and there was another article I just spread the word about, where they actually found the scorpionfish protein that kills Pseudomonas. And there's things like that. I think there's definitely one of the advantages is that when a scientist is thinking about, okay, I want to find a way to kill Pseudomonas, a lot of times they test it on extracts from CF patients' lungs. But remember, Pseudomonas is a problem in hospitals. There's a whole ventilator-acquired Pseudomonas issue. So we can benefit from the fact that there's a lot more people that are affected by Pseudomonas, and there's a lot of scientists trying to find ways to kill it without producing resistance.
I mean, it really is unbelievable because it's so terrifying when your kids have it, right? You're just like, ooh, this is it, you know?
It really is. And so I definitely have seen an increase in the amount of science of people trying to find ways to break down resistance, to find novel ways to kill these bacteria, because at least so far, even with highly effective modulators, we are not seeing a complete eradication of things like Pseudomonas, which means that we still have a lot of work to do in that area. Because as long as that Pseudomonas is chronic, you could potentially be getting lung damage, and that's the last thing we want in CF patients.
Yeah, it is so scary. And, you know, we talked about this too a little bit in the beginning about gene therapy, but what other thoughts do you have, you know, in regard to the final 10% of the population and getting a drug that, like Trikafta, would work for the entire population? How far out do you think that is?
Well, I think the good news is the real hope for the 10% is going to be in these mutation agnostic, which means it doesn't matter what mutation you have, gene and mRNA therapies. I think that's really the thing that's the closest and that will benefit them the most. As we've come to know modulators, these small molecules that Vertex and even some others have tried to do, I don't think you're going to see those for the 10% because of the reality of the different defects that are in the protein. But one interesting exception is a paper that was just put out by Martin Mentz from the CFF lab, along with other collaborative labs, where they were able to identify hundreds of rare CF mutations that are not currently approved for Trikafta, but that showed some benefit when analyzed in cell lines, and potentially enough benefit to be clinically meaningful. So that's called serotyping. So you take and look at all these different rare mutations and see whether they could benefit from a modulator. So there's definitely room for improvement there of getting more people carving out bits of that 10%. The other thing about a lot of the people in the 10% have what's called stop mutations. And for them, what you might call a modulator would be a drug that effectively read through that premature stop sign in the DNA And a drug like that would have broad benefits since over 7,000 diseases are caused by stop mutations. But unfortunately, all the efforts so far have not been able to achieve a breakthrough. But that doesn't mean people have stopped trying. Believe it or not, there's another thing called tRNA that some people are trying that might do a read-through of stop mutations. So I think there's a lot of hope, but the soonest thing I think you're going to see is these gene and mRNA therapies that would be potentially beneficial to the 10%.
Wow, that is hopeful and also very interesting, because I just talked to someone yesterday who is part of that 10%, and it's a lot mentally. It's a lot to be happy and see everyone else getting the help they need, but you're waiting.
I really can't imagine I think it's been hard enough for everybody waiting, again, with my long viewpoint, if you will, of the disease and patients, that they've waited and waited, and then they got modulators, which is great, but then anybody who hasn't been able to benefit from those modulators is waiting more. So it is something that I think I know the foundation, I know places like Emily's Entourage are laser focused on how do we get the rest of the people something that'll help them, whether it be something that'll help them right now or something for where we have a cure for everyone.
Right on. I mean, I think Emily EKG, as we all call her, if anybody's going to figure out the final 10%, she is definitely going to do it in Emily's Entourage and all of her supporters. I mean, they're working so hard. And for anyone that doesn't know Emily, she is among the 10% and has cystic fibrosis and has a great organization that's doing just incredible stuff around the clock. So yeah, there's a lot of hope.
There is. And Emily in particular, I've become very good friends with her over the years, and she inspires me. Whenever I feel down and I'm like, I don't know if I can keep doing this, I just think of Emily, and that's all it takes for me to jump back in.
Oh, that is so sweet. And I totally get it. She's inspirational. She's a fighter. She's doing it. She's speaking it. She's living it. She's inspiring other people. So yeah, we have a lot of hope in what she's doing, that it will help everyone, for sure. And then I don't know if you had any thoughts on any of these modulators and depression. I've heard so many different things. It's either that it was COVID and it's somehow connected to that, or is it the modulators that are bringing out depression in people who are already prone to it? I don't know the answer, but I wondered if you know or had any thoughts about this.
Yeah, I think this is a really good question to bring to me, and because I have seen a lot of anecdotal evidence, and they have just started to gather clinical evidence that there are trackable mental health issues that have risen for people that are taking the drug. And so I see it as kind of a two sides. So we know that's happening. So that probably means none of this is confirmed, but there is a chance that a modulator could be having an effect on your brain. And then that, like you said, might trigger in certain patients significant depression and other negative mental health issues. And then I think you had also mentioned at one point to me, there was just a recent study that showed the positive mental benefits being on a modulator. And I think that shows a little bit, exemplifies the variability in patients' response to any drug, as well as there's so many positive physical benefits that come from being on an effective modulator that I think that gives you a significant mental health boost, if you will.
Mm-hmm.
So you've got this kind of dichotomy, two sides of, for some people, the drug is going to be potentially so negative to their mental health that it's not going to overcome those physical benefits. And for others, the physical benefits are going to be so great that it might overcome any potential mental health issues that might be there, or that they're just not getting any, that's not something that's one of their side effects.
And it's so interesting. I say interesting, but I mean, it's very sad. It's very stressful. But, I've heard from so many people, 3 women in particular that I interviewed, and they shared it on a podcast, but they all had different reactions to Trikafta, and they had to go off of it, and they had to decide what was more important, and that's really hard to do. I mean, they're still living their life, but...
Yeah, I can't imagine having to make that kind of decision when you've got something that is potentially terminal, your illness, if you will, a chronic condition that's highly detrimental to your physical, but then you're having to deal with, do I continue where there's so many mental health effects? The 2 good news things is that both the next generation Vertex drug that's being trialed and is actually probably not that far away from approval might have a whole different side effect profile that could be good or bad for the mental health things. The other is there's a company called Sionna Therapeutics, and they are doing their own modulators, but their modulators at least are showing in their initial testing could actually bring you up to full, like wild type, if you will, normal correction on a modulator. And for something like that, there's no guarantees. Any drug can have side effects, but that sounds really exciting to me that we could have a couple other drugs available that might not have these issues.
That is, okay, this podcast is going to be like 4 hours long because I want to go back to what you said too. So that is really interesting about the mental health. And I think that's really important too, that you pointed out both that it can bring out depression and it can do the opposite, which is, well, for example, my girls, Molly was always the healthier one, but when she started Trikafta, she's like, wow, I can't even, now I'm even more healthy than I was before. And so that was a surprise to her and to us. And then Emily, who started out and had to go off it after a severe rash and reaction after 9 days, and then didn't get to go back on it for years. So she went into depression and everything that she's talked about publicly. And then when she went back on it, she realized, oh my gosh, how great she felt. But she also talked about how important it is to remember that if you can't be on it, you're still living your life, so it's important to keep in mind, kind of what everybody's going through. And then, yes, that next drug that's coming out from Vertex, what is it, about a year from now, maybe?
That might be a good guess. It really depends on some of the final bits of the trials and when they might be able to push an approval through from the FDA. So we'll see. That's the most common question I get on my Facebook group where I share research news out to about 6,000 people around the world is, when are we going to get something? And I'm like, I wish I could tell you exactly, but that, unfortunately, there are so many moving parts to getting a drug both tested and approved. It is a lot, and it can take a lot longer than we'd like it to take. But that's where patients have to do their best to stay healthy, to deal with that waiting game, which has got to be really, I can't imagine, to deal with that.
Right. And then too, I think, oh my gosh, I mean, this is like looking into the future in sort of a crazy Laura Bonnell sideways look. But I think, well, all these people who are on Trikafta now, when the new one comes out, maybe they'll say, okay, well, I want to try that one now. Maybe it'll be easier on me. Or you just have a lot of different variables that will have to be figured out, correct?
Yeah, that is correct. And then you bring up a little bit of an issue, which, again, we're going to go on here, but if you will, indulge me, that patients are going to also have to decide, am I willing to go off of a drug that's effective for me to try either a different drug or to try a gene therapy, which means that clinical trials become harder and harder to get people in because it is an ethical issue. And it's also that decision of each patient of, am I willing to stop doing something or potentially stop doing something that's really beneficial for me to try something that might be even more beneficial to me?
Right. That is a good point and something you'd have to think about. But yeah, I guess it would be helpful information, though, wouldn't it? Or maybe you don't feel like it's a gamble, or you would also have the opportunity to go back if the new thing didn't work?
It should be. There's not a lot of irreversibility, if you will, in these kind of trials normally. They have talked about maybe some of the gene trials at some point. It might be something you might not be able to do another gene trial once you've done one, but we don't know that for sure yet. But hopefully we can get patients enough information that they can make an informed consent and that it makes sense to them to do it. But you got to realize too, we're talking potentially parents with young children. They're going to also have to make these decisions, which being a parent is already hard enough. And then you got to throw on, well, how do I decide what's best in this crazy world of medicine to do for my child?
Right. And then you also are thinking, I was thinking it initially because there was so much that we didn't know. I wanted my girls on Trikafta right away, but I did also think, oh my gosh, this is kind of, you're still figuring it out, but it's been through the clinical trial, so I trust it, obviously. But, there still are concerns along the way.
There are.
And I also wanted to talk to you about if there are any other exciting treatments or therapies that you can share with us. And we're, in our show notes, it will say where people can connect with you on Facebook so that they can learn more from you. But what other treatments and therapies are you aware of that are being worked on?
So there's an interesting company called Cystetic, Cystetic Medicines, which they actually are looking at using an already approved compound that would act, they call it a molecular prosthetic. But what it does is it would form an ion channel in cells. So it would act like CFTR is supposed to act, but it's a completely separate process. So the idea would be you would have this inhaled drug that could potentially replace or replicate that function of a proper CFTR protein. And also interesting, as we both love EKG, Emily's entourage, they were part of the initial funding for that. And so that's pretty exciting that we might have some ways, and there are a couple other companies looking at ways to do things in alternate channels. So you don't even mess around with CFTR, if you will. You just get the proper function that it was doing and do it a different way. And that, again, would be mutation agnostic. Any mutation would be eligible and could potentially be a very exciting alternative way to get to the goal that we want to get to.
And how can people still get involved if they want to get involved in clinical trials and they want to, help as far as the growth of what's going on in the CF community? Is there more than just clinical trials, or would you just recommend that it is clinical trials?
So one of the things is Emily's entourage does have a patient registry where they actively connect people from a patient-centric viewpoint with clinical trials. On the CFF website, there's a way to sign up to know about clinical trials. I think the average patient, to me, the most important things for them is if they can keep themselves healthy, because we want them to live as long as possible till we have a cure. If they can be involved in fundraising or spreading the word or speaking out on what's happening with them and what's happening in the way of the advances in science, that's great. And then, like you said, I think it's important that they do their best to live their life to be a good example, because that is often picked up in the media, if you will. Someone who happens to have cystic fibrosis is out there doing good things, and that's always good to hear.
That is always good to hear. And is there anything else as far as cures being researched? I know you touched on it a little bit earlier in the podcast, but is there more coming from pharma that you're aware of?
There is. I think you will see the, like I said before, the gene therapies that are being tested in the lungs now, that's the first step towards a true cure. But one of the things for a true cure will be that you have to deliver that gene therapy to many, many of the cells in the body, which means we have to have a breakthrough in delivery vehicles. And the Cystic Fibrosis Foundation has actually invested a lot of money recently in companies that are looking for the best delivery methods. So I don't think the actual gene fixing part is not There's still some issues, but that's not a big issue as the delivery. And so often when I meet with the scientists, they talk about delivery. That's going to be our biggest challenge because we do have to get to so many cells to really give an effective cure for the patient. And ideally, that's going to be a one-time cure, so one and done. And it is hard to imagine that pharma companies would be motivated for a one-time cure when they can potentially make so much money from a modulator or a repetitive dosing strategy. But the good news is that there's been a couple other genetic diseases like sickle cell and beta thalassemia, where payers like insurance companies and governments have been willing to agree to a significant one-time payout for treatments that act as a true cure. So that means that while there's not the ongoing revenue, if you will, there's a big revenue bump from having an effective treatment for a patient. So I think there will be enough motivation, if you will, monetarily for pharma companies to figure out cures.
And we still may have a podcast part 2 with Bob Emmelkamp, but the underrepresented population, we saw this when there were clinical trials for COVID, still underrepresentation. We have so many stories about people with CF misdiagnosed even at 26. One of my board members, Ray Alder, because she's African-American, misdiagnosed. Do you think, at this level of, research, are we as a pharmaceutical community and scientists, are we doing everything we need to do to make sure that people of color and underrepresented populations are finally being better represented?
I think we're making strides. We're making steps in the direction. It's definitely something that both the foundation and a lot of the scientists that I know of are looking at. I think that means it's really important that there was just some new articles about extending newborn screening better so that we catch more cases early. Because one of the things you get is that with these underrepresented populations, the pediatrician or the people, involved in delivery, their first thought isn't cystic fibrosis when they see some of these, whether it be blockage or that things that we'd normally cue in on the typical population, they're not thinking the same way. And we need to do our best to enlighten on that. It also means that clinical trials are going to have to do better at recruiting diverse populations. And I think the good news is that the issue I told you about where we're having to enroll people in possibly that are already on something effective, the one good thing is that you might have in those populations that are underrepresented less people already enrolled, which means they might be eligible to try out something new right away.
And I have a question you may not be able to answer, but first I wanted to say in that newborn screening, like Michigan only tests for 60 of the, 2,000 mutations. And in other states, some of them only test for 4. So no wonder people with either rare populations or people of color aren't getting diagnosed. And then the doctor or the pediatrician, whoever is seeing them first, doesn't seem to understand some of them that, well, just because there was a negative test for CF doesn't mean they don't have it. It means that their gene wasn't represented. So there's so much work to be done. But I also wonder, and again, you might not know the answer to this, but what were we thinking back in the beginning? How were we coming to decide that only white people had CF? Like, how did that begin? Who thought that was, correct?
I think two things. It's definitely more common in the white population. So just by a pure numbers standpoint, it made, if you will, some sense to think that way. And then I think there was just the blindness of thinking, oh, okay, then it can't be in any of these other populations. And I know you probably know, we just lost one of our heroes, one of the Stenzel twins the other day.
Yes. Isa.
Their Japanese background, no one thought that anybody in Japan could have cystic fibrosis. And they were able to bring light to the fact that, yeah, it is probably over there. And it probably is some really rare mutations that we're not used to. But I mean, I don't see how there could not be some form of CF, or at least some mutation, whether that mutation actually affects your health or not, for the entire population of the world.
Right.
We know that genetic mutations occur. It would be likely to occur in this particular gene as much as any place else. And so I think to think that we know that it can occur in a particular population, I think is probably categorically wrong.
Right. I mean, I interviewed Dr. Grace Paul about India.
Mm-hmm.
They think they have 140,000 undiagnosed people in India. And now, granted, their population is enormous, but 140,000 undiagnosed people with CF, I mean, that's more than we have diagnosed in the whole world right now. So, yeah, I think raising awareness like you and I are is so crucial. I mean, people are dying because of lack of understanding and education. And, it's really sad. It's heartbreaking.
It is.
Well, we're not going to end on the heartbreaking note, but I really wanted to thank you because you have so much information and you really help the entire CF community understand science better and easier. Is there anything else that's kind of on the cusp or coming our way that we should know about, maybe even in regard to younger patients? I know everybody keeps saying if you're going to be born with CF, 2023 is the time to be born with CF because there's so much more medication and understanding.
Yeah, I think one of the things we've seen is that it is incredibly important if we can start any treatment. Obviously, the highly effective modulators would be the first choice. If we can start those as early as possible, it's going to make a huge difference. And I really think it has the potential, even today, to give someone basically close to a normal lifespan. So like you said, an amazing time to be born. But even more amazing, I just published or just put out an article. I can't say I take credit for these articles because I don't publish them. I know the people that do, but where moms have taken modulators carrying a baby that has CF, and basically the gastrointestinal issues were reversed by that, taking a modulator. So
wow.
It is really, that is something that I could never even imagine even 10, 15 years ago that we could have something like that would make a difference in an unborn child to basically heal them with a small molecule.
Well, thanks for sharing all your knowledge, and we will have to do another podcast so we can talk more with you and hear all the great things that you have to say. So thank you so much for sharing your knowledge with us for this podcast.
You're really welcome, and I would love to do another podcast with you. It's a great honor and privilege, and again, I've been really blessed to be able to be involved in this my whole life, and I need a cure for everybody because I need to have something to cap off my life, if you will, as well. So,
well, I am rooting for that cure for every reason that there is. So thank you so much. And yes, we will definitely talk again. Thank you, Bob.
All right, Laura, take care.
If you're looking for a good party, an event where you can mix and mingle with kind people, join the Bonnell Foundation on Saturday, September 9th for the Night of Hope Diamonds in the Sky event. We're going to have fun and raise a lot of money for our programs. See the ticket link in show notes or on our website. We'll see you there. The original music in this podcast is performed by Kevin Allen.
It's not complicated.
Who happens to have cystic fibrosis.
We all got our worries and fears. I know it's got you frustrated, but loving you is so alright.
This has been the Living with Cystic Fibrosis podcast. For more information and to learn more about the Bonnell Foundation, visit our website at thebonnellfoundation.org. That's the BONNELL Foundation.org. This podcast was sponsored by Viatris, Genentech, and Vertex. It was produced by Jag and Detroit Podcasts. Follow our show on Apple Podcasts, Spotify, or wherever you're listening right now.